Namaste Bitya, Hamesha Khush Raho Bitya. A very good morning to you all. Myself, JV and Dr. Ravi Jain, Assistant Professor, Department of Practice of Medicine in Faculty of Homeopathic Science at JAYOTI VIDYAPEETH Women's University, Jaipur. In today's lecture, we are going to discuss about Sjogren's Syndrome. In the last lecture, we had discussed about systemic sclerosis. I hope you must have gone through the book related to the systemic sclerosis, and you must all have studied the topic that we had discussed yesterday. In today's lecture, we are going to continue from the previous lecture. So what is Sjogren's syndrome? Sjogren's syndrome, it is characterized by salivary and tear glands that are getting affected with a predominance of dry, irritated and red eyes. There is dry mouth and there is difficulty in swallowing. So we have dry, irritated and red eyes. There is difficulty in swallowing and dry mouth. Now, what is Sjogren's syndrome? What is the etiopathogenesis, the clinical features, the investigation and the management? This we are going to discuss today in this particular lecture. So Sjogren's syndrome is basically a chronic and slow progressive autoimmune disease. So this is basically a chronic disease and it is very slowly progressing. An autoimmune disease because its own cells are directed against the own cells of the body. It is characterized by lymphocytic infiltration of the exocrine gland. So in the exocrine gland, there is lymphocytic infiltration and it is resulting in the destruction of the exocrine glands, which leads to the deficiency of secretion of these exocrine glands. So when the exocrine glands are infiltrated by the lymphocytes, these lymphocytes are destroying the exocrine gland, leading to extreme dryness of the area that is supplied by the exocrine gland. So this in the eye result into xerostomia and also the dry eyes. 1/3 of the patients that are present with systemic manifestations in case of Sjogren's syndrome. So Sjogren's syndrome is not only affecting the exocrine gland, but it is also affecting the systemic part of the body or the systemic manifestations. A small number of patients develops malignant lymphoma. So out of the total population, a small number of patients is developing malignant lymphoma, and it presents alone. It can present alone as primary Sjogren's syndrome, or it can be associated with other autoimmune rheumatic diseases that is known as secondary Sjogren's syndrome. So if this destruction is present alone, it is known as primary Sjogren's syndrome, and when it is associated with other autoimmune diseases, then it is known as secondary Sjogren's syndrome. Now we come to the incidence and prevalence. The incidence with female to male ratio is 9:1, and it is more common in the middle-aged women of the age group 40 to 50 years of age. It can occur at any age, including the childhood. The prevalence of the primary Sjogren's syndrome is 0.5 to 1% population. And 30% of the patients with autoimmune rheumatic disease suffer from secondary Sjogren's syndrome. So in the incidence and prevalence, we have female to male ratio is 9:1. There are middle-aged women. It is affecting the middle-aged women, especially of the age group 40 to 50 years of age. But it can occur at any age, including the childhood. There is prevalence of primary Sjogren's syndrome. It is 0.5 to 1%. With 30% of the patients with autoimmune rheumatic disease, they suffer from secondary Sjogren's syndrome. Now we come to the pathogenesis. Pathogenesis means what are the different changes that are occurring place in case of Sjogren's syndrome and how the changes are developing. So the pathogenesis is characterized by there is lymphocytic infiltration. Lymphocytic infiltration of the exocrine gland and the B lymphocyte hyperreactivity. So we have lymphocytic infiltration of the exocrine gland and the B lymphocyte hyperactivity. The sera contains autoantibodies to the non-organ specific antigens. We have autoantibodies to the non-specific antigens, and the major infiltrating cells in the affected exocrine glands are activated by T and B lymphocytes. The T cells predominate mild lesions, whereas the B cells are dominant in more severe lesions. So we have the major infiltrating cells that are activated, and T and B lymphocytes with the T cells that predominate in the mild lesion, whereas the B cells are dominant in the more severe lesions. The glandular epithelial cells undergo apoptotic death. So in the glands, they undergo apoptotic death, that is programmed cell death, by the signal provided by them to the T cells. And infiltrating lymphocytes not only provides apoptotic messages to the epithelial cells, but are also resistant to apoptosis. So these infiltrating lymphocytes, they do not only cause the epithelial cells to die, but these are also resistant to death. So they keep on sending the messages to the different type of lymphocytes and to the epithelial cells, leading to widespread death of these lymphocytes. So what is happening in Sjogren's syndrome is it is characterized by lymphocytic infiltration. So there is lymphocytic infiltration of the exocrine gland and the beta lymphocyte hyperactivity. The sera contains autoantibodies to the non-organ specific antigens. The major infiltrating cells in the affected exocrine glands are activated, and B and T lymphocytes are getting activated. The T cells predominate in the mild lesions, whereas B cells are dominant in more severe lesions. The glandular epithelial cells undergo apoptotic death by signals that are provided by the T cells. So there is apoptosis, programmed cell death of the epithelial cells, and these lymphocytes, they do not provide apoptotic message to the, they not only provide the apoptotic message to the epithelial cells, but are also resistant to apoptosis. Now, what are the clinical features? The clinical features of the Sjogren's syndrome. Whenever a patient of Sjogren's syndrome is coming to us, what are the various clinical features or the signs and symptoms with which the patient can present to us? The constitutional symptoms includes the fatigue. So the patient can present with the constitutional symptom of fatigue. It is also having Sicca syndrome. Sicca syndrome, that is keratoconjunctivitis and xerostomia. So dry eyes and dry mouth. The constitutional symptoms consist of fatigue. The Sicca syndrome consists of keratoconjunctivitis and xerostomia. There is dryness of the other surfaces, which includes the nose, the mouth, the vagina, the trachea, and the skin. So fatigue is the constitutional symptom with Sicca syndrome, that is keratoconjunctivitis Sicca, and xerostomia. Dryness of the other mucous membrane or the other mucous surfaces, which includes the nose, the vagina, the trachea, and the skin. There are various extraglandular features, which includes arthralgias or the arthritis, Raynaud's lymphadenopathy. There are also symptoms of interstitial pneumonitis, vascular, usually cutaneous, nephritis, and lymphomas. So we have constitutional symptoms of fatigue. There is Sicca syndrome with keratoconjunctivitis and xerostomia. There is also dryness of the other surfaces, which includes dryness of the nose, vagina, trachea, and skin. Extraglandular features includes the arthralgias or the arthritis. We have Raynaud's lymphadenopathy, interstitial pneumonitis, vasculitis, that is usually cutaneous, nephritis, and lymphoma formation. So these are the clinical features. So whenever a patient of Sjogren's syndrome is coming to us, then we will find that the patient is usually tired with having fatigue. In the Sicca syndrome, there will be keratoconjunctivitis Sicca and xerostomia. There will also be dryness of the other surfaces, which includes nose, vagina, trachea, and skin. We will also be having extraglandular features like arthralgias or arthritis, Raynaud's phenomenon, Raynaud's lymphadenopathy, interstitial pneumonitis, vasculitis, nephritis, and lymphomas. Sjogren's syndrome can affect the body in the multiple ways. There are multiple signs and symptoms and the multiple ways by which Sjogren's syndrome can affect the body. It can be responsible for development of various types of neurological problems with concentration or memory loss and dysautonomia. The nose can be dry with recurrent sinusitis and nosebleeds. There will be dry mouth and mouth sores with dental decay. There is difficulty with chewing, speech, and dentures. The patient will be fatigued always with vasculitis and dry skin. There are also abnormalities, abnormal liver function test with chronic active autoimmune hepatitis and primary biliary cirrhosis. The patient with peripheral neuropathy may have Raynaud's disease. The patient may have dry eyes with corneal ulcerations and infections. The lymph node may be swollen, painful, parotid and salivary gland. With difficulty in swallowing, there is heartburn and reflux esophagitis. The patient can also complain of recurrent bronchitis with interstitial lung disease or the pneumonia. Arthritis is also a common feature that is associated with Sjogren's syndrome and especially muscle pain. The patient also has stomach upset with gastroparesis, autoimmune pancreatitis, irritable bowel syndrome, and interstitial cystitis. The common features also includes vaginal dryness and vulvodynia. Now, majority of the patient have the symptoms related to the diminished lacrimal and salivary gland function. So because of the destruction of the epithelial cells, the secretion is diminished. Secretion of the lacrimal and the salivary gland are usually diminished. The initial manifestation can be mucosal. So there can be mucosal manifestation or non-specific dryness. And it may take 8 to 10 years to full-blown development of the disease. So initially there is dryness of the mouth and the eyes, and slowly and steadily it can develop fully. There is xerostomia. Xerostomia means dryness of the oral symptoms with difficulty in swallowing of the food and inability to speak continuously because the saliva is not getting formed. So there is dryness of the oral system and difficulty in swallowing of the dry food and inability of the patient to speak continuously. There is also a burning sensation with an increase in the dental caries. So because of the lack of saliva, there is increase in the dental caries, atrophy of the filiform papillae. We also have enlargement of the parotid and the other major salivary gland that occurs in 2/3 of the patients. The ocular symptoms includes sandy or gritty feeling under the eyelids. So we have sandy or gritty feeling under the eyelids, and there is burning and decreased tearing. There's redness, itching, eye fatigue, and increased photosensitivity. So the patient may also complain of sandy or gritty feeling under the eyelids, burning with decreased tearing, redness, itching, eye fatigue, and increased photosensitivity. The patient can also have keratoconjunctivitis sicca with the destruction of the corneal and bulbar conjunctival epithelium. In the other exocrine gland, we can also see there is diminished secretion of the upper and lower respiratory tree. So diminished secretion of the upper and lower respiratory tract tree, which leads to dry nose, dry throat, and trachea. So there is dryness of the nose, throat, and trachea, that is known as xerotrachea. Exocrine gland of the gastrointestinal tract, which includes esophageal mucosal atrophy, atrophic gastritis, and subclinical pancreatitis. So there is dry nose, dry throat, and trachea with xerotrachea. Exocrine glands of the gastrointestinal tract causes esophageal mucosal atrophy, atrophic gastritis, and subclinical pancreatitis. In the external dryness of the external genitalia, it produces dyspareunia and dry skin. Extraglandular or the systemic manifestations of case of Sjogren's syndrome includes, it is associated with rheumatoid arthritis. So Sjogren's syndrome is also seen with rheumatoid arthritis, and it consists of easy fatigability, low-grade fever with Raynaud's phenomenon, myalgias, and arthralgias. There can also be involvement of the lungs, that is pulmonary involvement, which includes dry cough with small airway disease. So we have dry cough and small airway disease. There is also renal involvement with the interstitial nephritis manifested by Stenuria, that is increased osmolarity, and renal tubular dysfunction, or with or without acidosis. There is also vasculitis that affects the small or medium-sized vessels that is manifested by purpura, recurrent urticaria, and skin ulcerations. Lymphoma is also a well-known manifestation that is present later in this illness. Lymphoma is manifested by persistent parotid gland enlargement, purpura, leukopenia. We have cryoglobulinemia and ectopic germinal centers in the minor salivary gland biopsy. Now, how to diagnose a case of Sjogren's syndrome? Sjogren's syndrome can be diagnosed by the presence of autoantibodies with the presence of anti-nuclear antibodies, rheumatoid factor, anti-RO-SSA, anti-LA-SSP. With the rise of ESR, CRC, CBC, renal, liver, and thyroid function tests are to be done. In the blood film, we will observe mild normocytic normochromic anemia. Ocular studies to diagnose quantitative keratoconjunctivitis sicca. Shimmer test can be performed and rose Bengal staining is done. In the oral examination, unstimulated salivary flow with dental examination is performed. Labial salivary gland biopsy can be done, which demonstrate lymphocytic infiltration and destruction of the glandular tissue. So how to diagnose? We have to check for the presence of autoantibodies. We have to check for CBC, ESR, renal function test, liver function test, and thyroid function test. We also have to go for the ocular studies and to check for oral examination. Labial salivary gland biopsy need to be done. Now we come to the treatment part. The treatment consists of regular follow-up with dentist and ophthalmologist. The dry eyes have to be checked for artificial tears, ophthalmic lubrication, and ointment are to be given. For xerostomia, that is dry mouth, frequent sips of water with sugarless candy is advised. In the case of sicca manifestation, pilocarpine and cevimeline is given. For arthralgias, hydroxychloroquine is given, and glucocorticoids are given for the treatment of extraglandular manifestation. So this was all about Sjogren's syndrome. I hope you have understood this lecture properly. I would advise or suggest you to go through the book, and if you have any query, then you can mention in the comment box. So this was all for today. This was all about the Sjogren's syndrome. In the next lecture, we are going to continue with a new topic. So this session is powered by digital version 2.0, JAYOTI VIDYAPEETH Women's University. I hope the session is clear to you. If you have any query, please mention in the comment box and I'll try to resolve it. So this was all for today. Thank you very much. Have a good day.